Hello, everyone. I'm Dr. Faulkner, and this is a med mechanics presentation. This lecture, Elemental MSK, is intended for my emergency medicine students who are completing the bone and muscle section, the module that's online. Now, for my sanity, as well as for yours, I have created this as a multiple part lecture, which means that this is just part one of two different parts. So please definitely look at and try to make sure you complete part two of this lecture to get the full value out of it. Now, to try to challenge you into being a little bit more active in your learning of this musculoskeletal section, I have included on many of the slides on the right-hand side multiple questions. And I would encourage you to try to answer those questions either by pausing this video or by trying to write them down so you can review them after the lecture. These questions will help you understand what it is that we're trying to get you to learn during this lecture. And I hope this will make it a little bit more interesting and inviting than just sitting down and listening to me talk for a little while. Now, one of the things that I think is really confusing about the musculoskeletal section is knowing which expert to send your patients to. So notice that there is a wide variety here listed: orthopedics, plastic, rheumatology, and sports medicine. A lot of the injuries that are on joints or a lot of disease processes luckily can be sent to multiple experts who can then figure out what to do with them. For example, hand injuries can go to both orthopedics and plastics. Sometimes joint injuries can go to both rheumatology, sports medicine, and orthopedics. So there's a lot of overlap of this. So try to pay attention to which expert you would refer to for each of the different diseases that we're going to go over. Now that brings us to why on earth I called this Elemental MSK. And that is because I kind of think about the MSK section as almost like little elements. There are multiple diseases made up of multiple different kinds of elements. So there are just some bone diseases, just like there are some muscle diseases. And that's the only problem that those diseases have. But there are a lot of complex MSK disease processes that involve multiple elements. So, for example, a joint is made up of bone, muscle, nerve, and connective tissue. Now, not only does the complexity then make this more confusing, but also the simple diseases, like just a muscle disease or just a bone disease, they all have individual names. And they all sound like different disease processes, even though it's all the same underlying fundamental principles. So what I'm trying to do is I'm trying to break these diseases down into their fundamental elements or their main element. So that way you start to see a theme over all of the MSK diseases. Let's move on and see if this works. So the most common distilled MSK disease process is going to be an overuse injury, right? So this is going to be some kind of person who does really high repetition or forceful exertion, or they have really awkward sustained postures. Whatever it is, this is going to be some sort of injury that is resulting from prolonged repetitive injuries. And it's not necessarily just a muscle problem or just a nerve problem or just a joint problem. Okay. Examples of this might be something like tendinitis or back spasms from bad back postures. You could have joint swelling. There's a multitude of different presentations for this, depending on which joint or which muscle or which bone we're talking about here. But the important part is that exam and history are really the biggest fundamental aspects of this. It's also really important to notice that I put plus or minus an MRI because MRIs show soft tissue better than CT scans. And you know, in the emergency department, we don't get MRIs very often, which is why these overuse injuries aren't something that we have to diagnose on a daily basis. However, patients don't know that, and they still come and seek out our help when they're having muscle aches, joint swelling, pain, etc. So what you need to understand is if you see this high repetition, forceful exertion, or sustained posture type injury, you need to know that what you need to do is refer them to somebody who's going to get them an MRI. I also want you to notice that the treatment for a lot of these diseases are going to be the same. And we're going to get into that here in the next slide. So the most common overuse injuries are going to be sprains and strains. Now, I know that some of you are like, I thought this was going to be an ER talk, but this is something that we see all the time, especially if you're working at an urgent care or a fast track. We see muscle strains and sprains all the time. Now, what you're going to notice here is that I've emphasized a couple of differences in sprains and strains, and that is strain with a T is a muscle problem, whereas a sprain with a P is a ligament or tendon problem. Yes, I know this sounds very orthopedic of me to bring up right now, but I want you to understand that there is a difference. Now, while both of these sprains and strains are graded very similarly, for example, if you have a grade 1, it's only a very small area of damage, whereas it goes all the way up to a grade 3, which is a complete tear of that area. And you can have multiple different partial tears, like is it 80% or is it 30%, right? The good news about this is in the emergency department, we don't care as much about the grades as we do about recognizing the difference between a sprain and a strain. Now, why would we need to recognize the difference? Well, one of the big questions here is which one is harder to recover from? The answer by far is the ligament or tendon injury is way, way harder to recover from than a muscle strain. Now, if you think about it, the muscle strain is the part that does almost all of the work, and the fibers contract to go ahead and give us our movement. However, the ligament and tendon doesn't have as much blood supply and doesn't really heal as fast, which can mean that having a muscle strain or even a broken ankle can be easier to repair and have a faster recovery process than something like a really bad ankle sprain. So people who roll their eyes at the patients who have a really terrible ankle sprain need to remember that ankle sprains can be in some segments worse and harder to recover from than a completely broken ankle. Let's go over a couple of examples here. So here are two really high level sprains and strains. What you'll notice here is that this Achilles sprain, you'll notice it's a grade 3 because it's a complete rupture. What you're noticing here is this is the normal. You can see the normal triangle here on the back of the knee, or I'm sorry, the back of the foot. And then on the other side, you're noticing that that triangle, that telltale sign is not there. If you look at these areas that I've highlighted for you, you can see that there's an obvious difference. The Achilles tendon has completely disappeared. Okay, this requires surgical repair. There is something called the Thompson's test, which you can squeeze the back of the leg and you can see if the foot moves. However, I don't think that the Thompson's test is particularly clinically relevant, at least not for me, because I can see clearly that the Achilles tendon isn't there anymore. Now, you can get a grade 2 or a grade 1 Achilles sprain. However, classically, these patients will present to you and say, I was playing fill-in sport here and someone stepped on the back of my foot, or I felt a really loud pop and then I couldn't walk anymore. These are very common complaints for an Achilles sprain. And remember that that Achilles tendon is a tendon injury, therefore it is only a sprain, yet it requires surgery. Now let's compare that to the hamstring strain that I have pictured over here. Notice that this is probably a grade 2, and I say that because this gentleman was still able to walk. Remember that if it's a complete and utter tear, he's probably not able to move that limb any further. But this usually happens with somebody who is like marathon running, for example, or extreme weightlifting. And every step is hurting him. And notice that he's having extreme soreness in the last mile or so and pretty extensive bruising. This was at the finish line of a marathon. So you can see here that this is probably at least a 60%, I'm going to guess, maybe a little bit further, more than 60% muscle tear. Now, notice that the difference between these two is both of them were playing sports and both of them just noticed an incredible injury, but they didn't know what the problem was until they came. This hamstring strain only requires rest. And I mean complete and total rest, not moving that leg, not running any further. And this will heal over about 2 to 3 weeks, whereas the Achilles sprain will never actually heal unless there's surgery. This brings us to our treatment. We always learned about RICE in medical school, and that's rest, ice, compression, and elevation. But recently they've added the P because they want to stress the rest part. You need to protect this area so it doesn't get re-injured, which means a lot of these sports players need to be told, no, when I said rest, I mean you really can't get up and play the next game. You can't go to practice. You cannot do what you're wanting to do. Unless, of course, you want to re-injure it. Another one is ice, and we'll get to icing here in a moment. You want to also compress the area, which will hopefully prevent some swelling, as will the ice. And you also want to elevate. Notice that nowhere in here is stretching, because this is not a cramp or a spasm. This is an actual injury. A sprain or a strain is not a cramp or a spasm. Now, I want to talk about this for a moment because I feel like in a lot of our discharge instructions, nobody knows what to put because we don't talk about it. And so a lot of these discharge instructions talk about stretching. And I want you to understand two big things. Stretching is controversial, which means that it's never been proven to be helpful or hurtful, except in some situations. And that is when we have an acute injury like a sprain or a strain that is actually visibly there. You get a lot of swelling, you get a lot of bruising, or you can see, like in the case of the Achilles, that it's completely, the tendon is gone. That area does not need to be stretched. As a matter of fact, if you have a 95% tear of the Achilles and then you stretched, imagine you hurting that tendon and then causing a complete 100% tear of that Achilles. So the last thing that we want to do in a sprain or strain is recommend stretching. The idea of stretching is all about preventing the injury rather than treating the injury. This is an important concept. Some sports medicine people seem to be arguing about this quite a bit, but at least logically, this makes sense in my mind. Please let me know if this isn't something that makes sense to you. But there is a lot of controversy around stretching. I just recommend that if you're in the emergency department and you have a sprain or a strain in a patient, do not recommend stretching. Highly recommend rest because we don't need an injury to cause further injury. Now, let's talk a little bit about immobilization, splints, and ACE wraps. The biggest question that we get is, well, I don't know what else to do for this patient. So what I'm going to do is I'm going to give them a splint or an ACE wrap. And a lot of times that these splints and ACE wraps can be really helpful because we want injuries like a sprain or a strain to be immobilized to allow that tendon or that muscle to heal. But we don't want it to cause a contracture. Remember that if we immobilize for too long, you can get something like a frozen shoulder, muscle atrophy, joint calcifications, and this can happen in even young patients. So we don't want to immobilize too long. Usually orthopedics always tells me that the magic number is 2 weeks. 2 weeks of not walking on something is usually a good amount of time, as long as it's not actually broken or completely ripped. For example, that Achilles sprain that we had that's completely ripped off, that's not ever going to get better, right? But if we don't have that person wiggle their toes a little bit, they could end up losing their mobility in their toes. This is why if you're going to ACE wrap or if you're going to do some splinting, it's really important to tell the patient's parents or the patient themselves that they need to take the ACE wrap or the splint off, wiggle and do full range of motion. Remember, this is not stretching, but it's full range of motion at least every week. So that way they're not getting frozen shoulder or muscle atrophy. It's also important, if you don't know what the injury is, to go ahead and refer to ortho, or to at least tell them in 2 weeks' time, you need to start taking this off and seeing how painful it is to move around. Now we got to have the big debate between ice and heat. There's a lot of people out there with a lot of different opinions on this, and I apologize if you're watching this years and years later and it's wrong. So know that you should always check this out because it seems like there's a new article that comes out about this every 6 months. But to me, the thing that makes the most sense is what I've put up here on the screen, and that is ice causes vasoconstriction, which causes blood to come to the area less, which means that the swelling will go down when you ice something. This makes sense to me. However, heat is going to do the exact opposite. Heat is going to cause vasodilation, which will then cause more blood to the area, which allows for faster healing. It also allows the muscle fibers themselves to relax. So if the problem is you're having a muscle spasm in an area that maybe is injured, for example, a fracture, heat can actually do just as much help in the acute phase as ice can. A lot of people get on their high horse and argue that heat will cause prolonged bleeding, which is true to some degree. Remember, it causes vasoconstriction, and that can also cause more swelling. But if you ice it, that can also cause the healing to slow as well. So there's pluses and minuses of both. Typically, a lot of folks say that in the short term, you should ice for the first 24 hours and then you can heat. I tell people to alternate. Remember that if you're telling people to alternate, like I'm doing, which hopefully is not wrong, you want to make sure that they're spacing it out. So you don't want to burn the skin, especially if they ice and then they immediately heat right after, or vice versa. You don't want to cause anybody to have frostbite or heat burns. So you want to have at least 30 minutes of time in between ice and heat. Now, if somebody has a broken ankle, you probably want to ice it for a little while. And if somebody has had a swollen knee or joint for a little while and the swelling seems to be the problem, icing would seem to be the better option. However, if you're having somebody who had an injury and they're repeatedly coming back for muscle spasms, say, then maybe heat is your best option to get as much of the inflammatory material in that area, which will cause some swelling, but hopefully increase the amount of relaxation muscle-wise, and also hopefully bring some blood and inflammatory areas to increase the healing. Hopefully that made sense. Remember that you just have to kind of think and logic your way through this, and this is rather controversial. Next, I just want to have mentioned to you at some point in your training that physical therapy is always pretty much helpful, and it's really nice to be able to work out and do range of motion with people who are trained to watch for form. I also would recommend that massage and acupuncture for lower acuity injuries like grade 1s or muscle spasms has been shown to help in reasons that we cannot explain. Whether that means that you're comfortable recommending them or not is up to you, but there have been some studies out showing that massage for muscle spasms and some degree acupuncture can help. It's sometimes worthwhile with patients who don't have anywhere else to go. Now we got to talk a little bit about these elements and their defense. It's really helpful, I think, to know each element and what it does when it's injured, or its defense mechanism, for example. If you understand its defense mechanism, then you understand the pathology of what's going on in the disease process. And you can understand and rationalize when we start combining these elements and what's actually happening with each disease process. So if a bone is injured, what it's going to do is it's going to make a callus, which means it's going to make more bone to sort of try to protect itself. If you understand that, then all of a sudden you understand arthritis. If you understand that connective tissue has no defense mechanism, doesn't heal very quickly, and just dies, then you understand why connective tissue injuries don't usually heal themselves. You also understand why connective tissue injuries require surgery. So you can see here that I've listed many different defense mechanisms for a lot of these different elements, just as an example. So I would recommend that you understand these processes so that way you understand how these are all going to work together. So let's start with talking about the element of bone. So, how do we examine a bone? If you have a patient and you're not really sure whether they have a bone injury or not, what do you do? I hope you didn't say x-ray everyone because that is not the right answer. I hope what you're saying is what's shown in this picture, and that is palpation. So I know that everybody makes fun of providers because something hurts, so we poke it, right? So if somebody is walking into your emergency department or brought in with the paramedics and maybe they're demented and they can't answer any of your questions, move their arms and legs around, palpate all of their bones. You'd be surprised at how often you will find something that the person couldn't maybe answer your question or couldn't tell you was the problem. Just simple palpation and knowing that wow, the arm shouldn't make that weird noise or that abnormal movement can really go a long way. As you can see here, this slide demonstrates the whole idea of questions, which remember, I'm not going to answer every single one of them. So now let's talk a little bit about fractures. One of the biggest questions that I had when I was a resident and for my students when they come shadow me is how do we know whether a fracture is emergent and I need to call orthopedics in right now or I need to transfer this patient? Or how do we know whether I can just splint them and then have ortho follow up in the morning? And I've included here a list of the things that I could think make all the most sense. And that is any open fracture, anything that's going to cut off the vascular supply, any kind of tenting of the skin, which is threatening to kind of push through the skin and become an open fracture. Any fracture that looks like it could be caused by abuse. And that's more of a social issue, but you don't want to discharge that person back home to then get further abused. And then, of course, anything that is limited as unstable, which means it's going to make their daily life or usual daily function worse. So, for example, you can have unstable cervical neck fractures that's going to cause paralysis, but you can also have unstable thumb fractures because if it cuts off the nerve to the thumb and they're no longer able to use their thumb, that could actually be a big job threatening inability to use their hand type of an injury. And then, of course, severe impedance of function. And that is a lot of the elderly folks who have a broken hip, for example. They can't walk. So, this is considered an emergent fracture because they can no longer get up and move around. They can't take themselves to the bathroom. They can't wash themselves, etc. So, this is how we determine whether a fracture is something that needs to be surgical or not. Now you can see I've included a myriad of different pictures here, but the big question is if you don't have a list of these memorized or you don't know a source, you need to have one. And I wanted to add in this picture here because just simply walking is not necessarily the only reason why we admit hip fractures. It's also because we have this big femoral artery that these pieces of broken femur can go through and cut the vasculature, which you can bleed out from. So I just wanted to add in that little extra piece of knowledge in case you didn't know. Now, this is my resource. I'm not paid to give you this information. I just think that OrthoBullets is free and it's the best site. I use it all the time. I don't have to memorize which fractures are emergent or not. What you can do is go to orthobullets.com. If you haven't already, I recommend you check it out. And then you type in whatever phrasing that the radiologist says or whatever you're seeing in the actual radiology picture, which you should be looking at. You can then stage it based off of the description that OrthoBullets gives you. And after you stage it, it can show you, for example, right next to the red arrow that I've included here, it'll show you whether or not something is surgical or whether you can send it home and have it follow up. This will save your orthopedist a phone call, I hope, unless there's abnormal findings, right? And it will also make you be able to talk to your orthopedic surgeon a little bit more intelligently. So I highly recommend OrthoBullets. Definitely check it out if you haven't seen it. Next is I want to make sure you guys know about the Ottawa Anka rules. There are other rules, including the Ottawa knee rules and the PCARN. All of these decision-making tools have been created so that way we know whether or not we need to image somebody or not. Now, I know that therapeutic imaging is something that has become more culturally relevant right now. And a lot of people just x-ray because that's what the patients expect us to do. But not everybody needs an x-ray. And it's really handy and helpful to know about these decision-making rules because you can quote them and use them as reasons in your chart why you did or didn't x-ray somebody, or CT them for that matter. It's another thing to understand that not all fractures are found in x-rays. So if you're pretty clinically concerned that this person does have a fracture, even though the x-ray doesn't show it, you can always do a CT of that area of the body, which will show a fracture if there is one. So a CT scan is actually better at showing bones than an x-ray. That's right. CT is better at showing broken bones than an x-ray. This is a really handy clinical tool. So especially for fractures, most notably your tibial tuberosity fractures, those always should be CT scanned. Now let's talk a little bit about how bones heal. And I know you're going to have a lecture, probably by an orthopedist, talking to you about all the different fractures and what you need to know about them. But a lot of patients talk to me about, well, I understand it's broken, or I do or don't need surgery, but what do I do from here? What can I expect? A lot of patients really appreciate you understanding how and what to expect with bone healing. So I want to take the time to explain that to you a little bit. So what you're going to notice here is that I've shown several different pictures of the bone, and what's happening is the bone will heal. Remember that a bone's defense mechanism is callus making. So new bone is actually a little bit thicker and a little bit, I guess, like deformed than previous. This is how we can tell if the bone has healed up all the way or not. And so you can see that this is a fresh fracture. This is within 6 weeks, and this is within 6 months. Now, that doesn't mean that bones heal within 6 months. As a matter of fact, it also depends on your age. You can see from this picture down here below, this fracture is that of an infant. And you can see this same fracture day 4, day 10 with this white cloud of bone all the way around it. Then after just only 2 weeks, and then after 6 months, this doesn't even have a callus around it. This is completely new, solid, strong bone. So one of the helpful things to know about is children's bones are going to grow back, and there's not going to be any callus. They're almost a little bit stronger than they were before, or at least the same as they were before. Whereas in an adult, that's not going to be the case. New bone is not as strong in adults as it was before. This is where arthritis comes into play. One of the things that I tell my patients is that bones take 6 to 8 weeks to heal. And some people are a little bit longer, some people are a little bit shorter. One of the most common factors that causes bones to heal slower is going to be diabetes or nicotine specifically. Those two things really cause bones to heal slower. So if you can tell somebody that they've been thinking about, stop smoking, and they could maybe cut down or stop smoking altogether for the next 6 months, they will heal faster than if they continue to smoke for those 6 weeks. Now, again, 6 months is not what I tell my patients. I tell the patients 6 weeks is what it's going to take for the bones to come back together and be at least a solid, sturdy bone for the rest of the muscles. But notice that there's still holes in it. And for complete and total x-ray healing, 6 months is the right answer. So I tell patients it takes 6 to 8 weeks to heal, and then 6 months to be back to the way it was before. Now, I want to point out a little bit when you're looking at x-rays for how you tell the difference between whether it's a new fracture and whether it's an old fracture. And again, I've already given away the answer here, and the answer is just about calluses, right? So you can see here from the arrow sign what the edge of this fracture looks like is it looks extra white. It has made that callus already that we were expecting from a healing fracture. That callus is what's showing us whether it's a new or an old. If you look at this area right here, you can see that it's almost translucent and it doesn't have a white edge in this fracture area right here. That shows no cortication. So that's got to be probably within the last 2 days of fracture. You can see the same thing here in this area of translucent bone, but you can also see this white cloudy area. So this is a healing fracture, although it's probably only within about the last week. And you can see this here as well. Does that have a cortication or not? If it does, then it's definitely going to be old. And if it's new, it's not going to have that cortication, that white area, or that cloud around it. Hopefully that makes a little bit more sense. Now we got to talk a little bit about pediatric bones because pediatric bones are a little bit different than adult bones. So the first obvious answer in how they're different is growth plates, right? They're still getting longer and bigger and they're still growing. This is the area of growth. So you can see that the arrows are showing you where and how the bone is growing. It's growing in both directions. So the head, the capitellum is getting bigger and the shaft is actually getting bigger. Now, this also matters in age because what you can see in the staging process is that when babies are born, the majority of their bones are still cartilage. Cartilage is a lot harder to injure, but it's a lot bigger deal if it has been injured. This is why babies can pass through the birth canal relatively rubbery, right? It's also meaning that if a newborn baby gets dropped, they don't suffer the same fractures as maybe say an 80-year-old who gets dropped, or maybe a 20-year-old who gets dropped because their bones haven't completely calcified yet. The older a child gets, the more calcified the bones are. And this is why puberty matters. Usually at the end of puberty, those growth plates close. And that's how we know that that child or person is not going to grow any further. And that's how their bones become an adult. It used to be that this was happening around 16 to 21, but some people have noticed that this age is actually getting younger. So something interesting to follow for sure. Not exactly sure why. This also means that bone fractures are going to look a little bit different in children. So what I'm showing you here is that because the bones are cartilage, they can actually be springy. So there's a special fracture called the torus or the green stick fracture. And you can see the picture of the stem. If you bend the stem in half, kind of like if you bend a green stick in half, it doesn't break all the way that a normal adult bone does. It only breaks partially and only on one side. This is only possible because the bone is still significantly portioned to be cartilage. So we're looking at green stick fractures probably in the ages of 6 and younger. And again, this age isn't exact defined. Some people grow a little faster, some people a little bit slower, but you can see that a green stick fracture is only possible in a child. And it's only because their bone is still not completely ossified. Same is going to be true about Salter-Harris fractures. Why do we care about Salter-Harris fractures? It's because if the growth plate is involved in the fracture, this means that the growth of the bone is going to be involved, right? So here's an example of a growth plate fracture that's causing a crooked bone 2 years after the injury. You can see that one side of the bone over here grew appropriately, whereas because the fracture went through the growth plate right at this area, it didn't grow further, and that caused the bone to be crooked, which maybe caused a limp or maybe causes them to not be able to walk like usual. This is why we care about Salter-Harris fractures. Another thing that you should know is not all bone issues are caused by fractures. A perfect example of this is avascular necrosis, also called AVN. AVNs can occur with a fracture, although they don't always have to. Remember that bone is tissue that's alive. So if we cut off the blood supply for some reason or another, that can definitely cause a bone to die. We care about avascular necrosis, A, because it hurts like a son of a gun, and also because avascular necrosis causes the death of part of the bone. And if that bone dies, or at least part of that bone dies, that's going to be an area where fractures can happen. It's not going to be a supportive structure like we want it to. And it's also probably not going to make the appropriate amount of blood. That's the bone's whole job, right? You can see here that I've given a giant list of causes of avascular necrosis, and you should definitely check that out. There's some diseases that are more prone to this than others. Another just bone disease is going to be arthritis. Again, you remember that bones are defending themselves with callus formation. And so for some reason or another, maybe it's an immunology problem, or maybe it's because of cartilage breakdown from old age, but whatever the issue is, there's going to be damage. And so the bone is building up extra bone to cause callus formation. You can see here an example of osteoarthritis versus rheumatoid arthritis. And osteoarthritis is going to be more of a old age, or the cartilage isn't present anymore, usually due to old age. And then rheumatoid arthritis is going to be a autoantibody issue, like an autoimmune disorder. There are a bunch of autoimmune arthritises, and I've listed here several for you. Obviously, gout and infectious are not always an autoimmune disorder, but they are ones that can cause breakdown and buildup of callus formations and arthritis in the bone. Another big bony disorder is bony metastasis. So not all the time, but sometimes metastasis causes pain. And metastasis also causes pathologic fractures. Like somebody who picks up a coffee mug, for example, shouldn't be breaking their arm because they picked up a coffee mug. That means that the bone was most likely already weakened, and that could be because of a metastasis. So it's important to know the most common cancers that go to bones, because there's really only 4 of them. And it's also really important to know that the long bones are most likely to be involved. So definitely take a look at that. It's really good to know all of those percentages, but I don't recommend memorizing them. It's just more for your knowledge. Now we can get into muscles. So when we do a muscle examinations are almost exclusively all about range of motion. That's why it's so important to go up to the patient and ask them to move their arm around in flexion and extension, and to even do it against resistance. Sometimes doing it against resistance is the most important part of a muscle examination. And that's what's going to reveal to us tendon or ligament damage that we may not have noticed otherwise. So definitely make sure that you're doing a full muscle examination of an area that you're worried about, a laceration or a tendon or ligament damage. Now we got to talk about muscle spasms, because everybody tends to blame every muscle ache and pain on a spasm. Some of this is because it's so common, but some of it is also because they're like, well, I don't know what else it could be, so it must be a muscle spasm. So muscle spasms are caused a lot by injury or trauma, but they're also caused by overuse and electrolytes They can even be caused by nerve injuries. Remember that if we're having something like a paralysis or Babinski, that can cause lower muscle spasms. Same with temperature. If you have somebody with heat stroke or a fever, for example, you can have muscle spasms. And don't forget about medication side effects. Like if you've ever intubated somebody, you know that succinylcholine is going to cause all of those crazy muscle fasciculations. So muscle spasms are caused by such a huge wide variety. It's also important to make sure that you're looking out for all of the most obvious common signs. So I'm showing pictures here of torticollis. Torticollis is the sternocleidomastoid in your neck that is causing one-sided spasm of the neck. This can be caused by a medication side effect like the psych drugs, or it can be congenital, or it can be from electrolytes or overuse and trauma. Another muscle disease that we need to talk about is rhabdomyolysis. Rhabdomyolysis is something that we worry about in the emergency department and is something that I think a lot of people overcall. So it's important for you to know that the magical, test of rhabdo is going to be a UA, and it's also going to be getting a CK or creatinine kinase. This is not the same as a CKMB. Make sure you know the difference. But a CK is going to be anywhere between 22 and 200 about. In order to be true rhabdo, you need to get something that is 5 times the normal value. So 200 times 5 means that you need a number that is about over 1,000, right? So a rhabdo that is high, like let's say it's 500, may indicate some good muscle breakdown. That's what CK is, right? It's muscle breakdown, but it's not causing rhabdomyolysis, or it's not overwhelming the kidney with so much muscle breakdown products that their urine becomes tea colored, unless it's in the thousands. So they may require hydration, or they may have been running a whole lot, or they may just be older. Remember that myoglobin, which is what we're looking for, that's that muscle breakdown product, is going to overwhelm to the kidney to the point of failure. That is the definition of rhabdomyolysis. It's not a simple CK of 500. Again, it's got to be 5 times the normal to be true rhabdo. I have seen true rhabdo that has caused liver failure as well as kidney failure. That is always bad. Those folks need to go to the ICU. The cure or treatment for rhabdo is a lot of hydration and a lot of time. So you want to hydrate up those kidneys so that way you can hopefully flush out all of that myoglobin, and you want them to rest. These folks are going to be tired. They're going to be sore. Their muscles are breaking down for some reason or another. So we need to give them lots of rest, lots of sleep, lots of nutrition, and most especially lots of hydration. Now we're going to talk about tetanus. This is a disease that we talk about a whole lot, but we haven't really seen a whole lot of. And that's because we do a lot of vaccinations. So Clostridium tetani is what causes tetanus. And it's infectious, as in you typically are in contact with the bacteria, but it's not contagious, which means at least not human-human. So if you knew somebody with tetanus, you wouldn't have to be worried that this person was going to give you tetanus. Usually, tetanus lives in the dirt or in rust, and the spores kind of get deep into puncture wounds, which is why we always give a tetanus shot for somebody who stepped on a dirty, rusty nail. This is what tetanus looks like. And I found this picture online because tetanus has started to make a resurgence in some of the third world countries, I guess, in like Africa and Central America. I've started hearing a little bit more and more about tetanus making its resurgence. Tetanus has been around for a long time. You can see this picture of a person below here that was from like the Middle Ages. So tetanus has been known around for a long time. Not all cases are this intense. These people look like this because the back muscles are so much stronger than the front muscles that they cannot release their muscles and they're just contracted. Usually people can train in contemporary times complain the most about jaw muscle spasms first, and they're usually intermittent, so they're occurring in about like 10 to 20 minute spurts, and it can last for like almost a month. So can you imagine not opening your mouth or not being able to eat or move around like you want to? I mean, what you're seeing here only lasts about 10 to 20 minutes, and then they can relax, but they can't control when it does and doesn't happen. This is why these patients have to be admitted to the hospital. They can't drive, they can't walk, they can't take care of themselves. This is why we always want to do a tetanus shot. So let's talk a little bit about the tetanus shot, because it's also something that, because everybody knows about it, I think we give it a little bit too often. So the general rule of thumb is that we give tetanus or the booster every 10 years. So Tdap, which is combined with pertussis, is given at 2, 4, and 6 months. And then it's given again anywhere between 15 to 18 months. And then last, it's given 4 to 6, right? So it's given quite a few times in our youth. And then it's given once, Tdap needed about 11 or 12 years old. And that's the last time it's given. So that means that if you have a 24-year-old who steps on a rusty nail, do they need a tetanus shot? Well, they probably got one at 11 or 12. So it's 10 years. The answer is yes. They absolutely need a booster. So remember that just because they're young doesn't mean that they don't actually need the shot. And you also have to ask a lot of adults about it, because a lot of them don't get that shot every 10 years. It gets forgotten about a lot, but it also gets given too often. So what happens to somebody if they get given a tetanus shot? Let's say they had one last year and they had one this year. The answer is not a lot, at least not that we know of. But we haven't really studied anybody who's gotten the tetanus shot every single year in the last 5 years, because it's not really an ethical study to do. So I would recommend that we probably be careful about giving a tetanus shot. And if it's a contaminated wound, which means that there's dirt or rust involved, it has to be within the last 5 years. So again, really think about whether they need a tetanus shot. The last big muscle disorder that I want to go through is something like fibromyalgia. And I wanted to specifically talk about it because everyone rolls their eyes when they hear fibromyalgia. A lot of people don't believe that this is a real chronic pain syndrome, and they think that people with fibromyalgia, are making it up, or they just have some kind of pain syndrome and they just want pain medications. To get the diagnosis of fibromyalgia is actually supposed to be pretty hard. You have to have 9 specific tender areas, along with sleep problems, fatigue, restless leg, and it seems to be predominantly in females. A lot of people think that fibromyalgia represents multiple disease processes that we don't quite understand yet. Some people think it's linked to estrogen, but nobody really knows. And fibromyalgia is still very controversial. The important part about fibromyalgia that I hope you already know is that luckily we in the ER don't have to treat it, but it's really important that you know that they could have some other kind of muscle disease on top of the fibromyalgia. So important to know, definitely think about the other muscle problems. And that concludes part 1 of our musculoskeletal. Remember to look out for part 2.